the question this morning is the safety of biologics. So what are the tools we have to evaluate the safety of biologics? We have several tools which are indicated on this slide. There is no one good tool and the other are bad. It is a complementary, all these tools have to be used, and when a message is given by all these tools, you can think that this message is correct. RCTs are the gold standard because, of course, the patients are randomized. You have the placebo group and you have the treated group, but, of course, the patients are highly selected and the follow-up is short. Extension of RCT is interesting, but the selection of the patient is huge. Only the good patients continue the drug. Registries was going to speak about, and clearly is an interesting tool, but there was also the post-marketing follow-up. You are going to see that TB with anti-TNF was found like that. And we can organize the post-marketing. It is what we did with the ratio observatory. We just focused on TB, opposing infection, and lymphoma all over the country. So we collected all these cases. So registries really are something interesting for assessing the long-term safety of the drugs. There is no selection of patients. It is real-life patients with comorbidities, and that's very, very important. And there is a long-term follow-up. It has been calculated that the patients in registry, between 10 to 20% only, 10 to 20% could have been included in RCT. So really it is the real-life patient that we see every day in our office. But there are some limitations, like with every technique. There is no randomization, and the characteristics of the control group are, in most of the cases, very different of the characteristics of the treated group. So we have to adjust. And we have now a good technique of adjustment, but it is always tricky to do that. And you also have this long-term survival effect. I will speak of that in the next slides, because like in extension trials, you select in the time the patients who tolerate the drug. What the analysis to do in registries, maintenance is a good compromise between safety and effectiveness, but serious infection, of course, is important, and you are going to see that they have to be analyzed early to avoid this bias of long survival effect. And conversely, opposing infection and cancer and cardiovascular events have to be analyzed during all follow-up. And now we have the first data, essentially from Germany, about mortality of patients on biologics from registries, and I will share this data with you. Here are all the registries in Europe, and you see there are a lot of registries. The technique is not the same for each registry. Some of them concern only one drug. It is what we have in France. Other one includes all the disease, all the drugs, and I think it's better to do that when we can. But you see that the methodology is not the same. It can be a shame that in Europe we were not able to set up a unique registry. But at the end of the day, finally, it's good to have different techniques, different registries. It is like in genetics. And when something is found in one registry, it has been replicated in the others. But anyway, we try to do some merging, and we have now some efforts for merging some registries. For example, some rituximab registries, the adalimumab registries, and it can have more power for detecting rare events. Of course, I didn't put on the slide the American registries, and you have in this country a very strong registry which is called Corona, and there are also a number of very interesting registries in Canada and all over the world. So let's begin by TNF inhibitors, and we're going to see what are the most safety issue we can conclude now in 2015. You all know we have now 5 drugs, 3 mechanisms of action, soluble receptor and monoclonal antibodies, classical monoclonal antibodies, and the 5 here, which is fused to the pegylated for certolizumab. So here are the main safety issues we are wanting to address. The first one is serious infection. First, serious infection, let's begin with RCT and meta-analysis of RCT, which has been done by the Cochrane. And you can see that serious infection is in the bottom. Overall, there is no statistical increased risk of serious infection in biologics versus placebo, but some of the drug may have an increased risk, and there is clearly it's not 1, there is the odd ratio is 1:19. So what do tell the registry? The registries are very puzzling and very confusing, the data from registries concerning serious infection. is the first paper, 205, a second, no risk, a third, different risk, 4, 5, 6, very confusing, but at the end of the day, it's very clear. And all the registries agree about that. There is an increased risk of serious infection at the beginning of the treatment with anti-TNF during the first 6 months. And after 1 year, the increased risk disappeared, and the risk of serious infection is roughly the same as the risk of serious infection with classical DMARDs. Why is this type of curve? For different effects. And the first one is the selective dropout for the cohort in high-risk patients. And clearly, that's very important, this healthy drug survival effect. Of course, the patients who don't tolerate the drug or the patients for whom the drug is not effective are going to leave, are going to withdraw and to take another drug. And these patients will not be present at 1 year, 2 years, 3 years, and so on. And it has been demonstrated that these patients who stopped a biologic in the first 6 months for a safety events, we have more serious infection in other, when they will take other drugs. So this bias is very important. But there is also two true effects which could explain the decreased risk of infection with time. The first one is activity of the disease is a risk factor of serious infection. And with time, you are going to decrease activity of the disease. And the second factor is co-medication. And of course, these patients with active disease are treated with steroids, and if the disease is better, you can decrease steroids. And the methodologist of the German registry, which is Joachim Listing, tried to modelize all these factors in order to be able to predict the specific risk of serious infection for specific patients in whom you begin a specific treatment. And look at this data. They separated the risk factors depending to the patients, depending the treatment. You see DMARDs or TNF inhibitors, and also just the steroids in this model. Take the example of these patients with COPD, 65, he has 2 comorbidities, so he's on this line, and he's treated with DMARD and with high dose of steroids because RA doesn't go well. So you decide in these patients to introduce anti-TNF. You increase the risk of serious infection from 12 to 21. But very few weeks after, the patient gets better, and the steroid is decreased from 17.5 to 12.5. And the risk of serious infection come back to 12, exactly the same as at the beginning. And as a patient continues to be well, you are continuing to decrease steroids, and now steroids is 5 milligrams. And at the end of the day, by starting anti-TNF in these patients, you will have decreased his risk of serious infection. So that's very important to take into account when you decide to do or not to do anti-TNF in a patient. What will I do if I don't introduce anti-TNF? And if I increase steroids, I think it's not a good game for the patients concerning serious infection risk. And you see that this has been modeled in the rabbit registry, the German registry. In half of the patients, it is in blue, and in the other part of the registry, it tested the hypothesis, tested the model, and it works remarkably, as you can see on this slide. So now they have a website, this rabbit registry, and this website, you can go in this website in English, and you can calculate for one patient, you enter the characteristic of the patient, the treatment, and you will have the risk of serious infection in the next year. It is like the FRAX tool for osteoporosis. So that's very interesting. Is the risk of serious infection different between the type of anti-TNFs? In most of the cases, no. I speak here of classical serious infection, and you know that the most frequent serious infection is pneumonia. And you can see here on the rabbit registry that there is an increased risk of serious infection at the beginning, as I have said, and it is the same with all the anti-TNF. And you can see that after 1 year, this risk has disappeared. In other registries, the risk of classical serious infection is higher with monoclonal than with etanercept. It is the case in the DREAM registry, which is a Netherlands registry. You can see here that the risk of serious infection is a little higher with adalimumab and infliximab than with etanercept. Last but not least, to finish with serious infection, we have this data from the SABER SABER is an insurance database from the US with millions of Americans using this insurance. And so we have very interesting data from these insurance databases. You see the number of patients with autoimmune disease is huge, and the patients with rheumatoid arthritis here have been apparent with patients with anti-TNF and patients not receiving anti-TNF with a propensity score that the two type of patients as close as possible. And they did the same with inflammatory bowel disease and with psoriasis spondyloarthritis. And they compare the risk of serious infection when you begin anti-TNF and when you begin other things. Because sometimes you just compare anti-TNF versus methotrexate. But we have, in real life, the patient is not well. So you think to beginning anti-TNF, what do I do again if I don't begin anti-TNF? So initiations of tree therapy or so, and other classical DMARDs. And the results are there. There are absolutely no difference in the risk of serious infection, either in RA, in inflammatory bowel disease, or in spondyloarthritis, or psoriasis, as you can see here. There were some small differences between the drugs again. And you can see that in infliximab, the risk of serious infection was higher in infliximab, and higher with infliximab than with etanercept, and higher with infliximab than with adalimumab in this American cohort. What was very interesting in this cohort also is that the demonstration again of the infectious risk of steroids. You can see here that even low dose of steroids, you can see there, increase the risk of serious infection by 32%. So that's very important when the patient is well on anti-TNF. Don't forget to decrease steroids, and if possible, to stop steroids. My objective in a given patient is steroid 0 if I can achieve this objective. Of course, in early RA, it's frequently possible. In long-term duration RA, it's much more difficult. But that is something we have to keep in mind. And there was this editorial from David Felsen, who is a provocative question in the paper in the JAMA. So, what about TB, which is a concern in patients with anti-TNF? Interestingly, TB, the risk of TB was not found in phase 3 study. And as I told in the introduction, it is only after the infliximab was on the market that you see that the phase 3 study, there was no difference in TB. And in 2001, this paper in the New England Journal of Medicine showing that the risk of TB was clearly associated with infliximab because these 70 cases occurred in the first 3 months of the treatment by infliximab. So it means that it is reactivation of latent TB, and now in every country all over the world, we screen for latent TB before beginning anti-TNF in the patients with inflammatory disease. And this screening works. It's very interesting, this paper recently published by the Swedish. It is the incidence rate of TB in Sweden, the general population. It had 2 periods. And 10 years, that's the current period and 10 years before, a small decrease in general population, a small decrease in rheumatoid arthritis treated with classical DMARDs. You see there is an increased risk. But very interestingly, there is a clear decrease of TB in rheumatoid arthritis treated with biologics because thanks to the screening we are doing in this patient. There is still an increased risk, but the difference now is getting lower, and it's a very good thing that now the risk of TB still exists, but we can manage it better. What is also clear is that the risk of TB is higher with monoclonal antibody than with etanercept. It's higher with the 4 monoclonal antibodies. It is the same for the 4 and different with etanercept. You see that's also a systemic analysis of all the registries. It is 3 to 4 times higher with monoclonal than with etanercept. Why? And it is the same for non-TB opportunistic infections. We did this study in France in the Ratio Observatory to collect all the non-TB opportunistic infections. And you see, we collected 45 cases, and you see that if you compare to etanercept, the risk was much higher with the 2 monoclonal antibodies, and of course, also much higher with steroid use. In the US, you found exactly the same data, and Kevin Winthrop published this nice paper concerning the risk of TB in the US. In the US, it is a low incidence of TB, of course, but you see there is a difference between etanercept and the monoclonal also in the US. Interestingly, in the US, non-TB mycobacterial disease is more frequent than TB. And again, you find this difference between etanercept, and the monoclonal antibody. But remind that these opposing infections are very, very rare. And of course, there is a differential risk between the soluble receptor and the monoclonal, but it is very rare. And concerning the classical bacterial infection, in most of the registries, there is no difference. So why is there this risk, differential risk, of opportunistic infection between soluble receptor and the monoclonal? And it is the interest of registries and coming back to the lab and trying to understand the differences. It is clearly due to the fact that the granuloma is made by macrophages, monocytes, which express membrane TNF. And this membrane TNF may be binded very efficiently by monoclonal and less efficiently by the soluble receptor. So if you have been in contact with TB 20 years ago when you were a child, you have still some TB bacillus within this granuloma. And this granuloma contains a lot of membrane TNF. And if you disrupt membrane TNF, the bacillus, TB bacillus can go out and can give reactivation of latent TB. And you can see on this slide the binding of the different anti-TNFs to TNFs. To soluble TNF, it is exactly the same. Etanercept and the monoclonal bind with the same affinity, the same stability. But concerning membrane TNF here, the binding is much more stable with monoclonal than the soluble receptor. So what happens when this drug binds membrane TNF? A number of events occur in these cells, and this event can be CDC, ADCC, reverse signaling. And these cells which express membrane TNF, they are monocytes, macrophages, NK cells, some T cells, and they may be important, of course, for immunosurveillance. Third, very important question, what about cancer? 15 years after beginning using anti-TNF. You all remember this provocative paper in 2006, and we were all very, very worried. And I asked myself at that time, I remember the presentation as a late poster in ACR. When we saw that, some people said, are we going to stop to prescribe anti-TNF? Because if it's true, really, it will not be possible to increase so much the risk of cancer in our patients. But it was a meta-analysis of RCT with infliximab and adalimumab. But there was a number of weaknesses in this meta-analysis. I don't understand how this prestigious journal, which is a JAMA, accepted this paper. Look at these weaknesses. The cancer were analyzed by person and not by patient years. And that's a big mistake, because if you look at the rate of cancer at entry, we have 12% of the expected risk for malignancy in the placebo group. It reflects the high selection of the patient, because the patients in RCT are very highly selected. Because of the screening, you can screen small cancer, etc. Over time, the risk of cancer in this population is going progressively to reach the classical risk of cancer on the age and matched sex population. As the follow-up is longer in the patients with anti-TNF, because they are better, of course, you are going to disadvantage the anti-TNF versus the placebo because you analyze in patients and not in patient years. And it was really a big weakness, but we have always that in mind, TNF and this meta-analysis, because all the data after are really reassuring. I show you again another meta-analysis which was asked by EMA, the European agency, and Johan Askling, a very brilliant epidemiologist in Sweden, did this meta-analysis. And all the RCT with anti-TNF, and here are the results, between placebo and anti-TNF. No risk of cancer, except a signal for the non-melanoma skin cancer with a twice increased risk of non-melanoma skin cancer, but we do know that this type of cancer may occur with different type of immunosuppressor drugs. So what do the registry tell about the risk of cancer? With other European experts, we tried to do a meta-analysis of registries. It was something new at that time. So we put all the registries together and we look at the risk of cancer. And as you can see here, there is no increased risk of cancer in patients treated with anti-TNF compared with patients treated with classical DMARD with the control arms adjusted as well as possible of the different registries. The only signal we saw was exactly the same as the signal which was seen in RCTs. And that's interesting again, when the same signal is found by two different techniques. A small increased risk of non-melanoma skin cancer, as you can see on this slide. There is also another signal concerning cancer. It is concerning melanoma. Melanoma, this signal comes from the ARTIS registry. You can see here, if you compare melanoma risk in patients with anti-TNF versus classical DMARDs, there is a trend to an increase 1.5. But very recently, it's not yet published, we put all the registries of Europe together. It was an initiative of EULAR, which is called ROC, and it has been presented at ACR last year. When putting all the European registry, we didn't find any increased risk of melanoma in patients treated with anti-TNF compared with patients treated with classical DMARDs. Again, when we look at SABER, SABER was very reassuring concerning cancer. Whatever the model is used, whatever the type of cancer, all cancer, lymphoma, non-melanoma skin cancer, no difference of risk between anti-TNF and between the change for another type of classical treatment. Last, we have also data from the BSR-BR, which have been published recently concerning cancer, and which were not all in the meta-analysis. And again, by drug, it is exactly the same. You see there is absolutely no signal in favor of an increased risk of cancer, either with etanercept, adalimumab, or infliximab. And we have had recently this paper from Taiwan, provocative paper showing that the risk of cancer should be decreased in the patient treated with anti-TNF. Taiwan has a very good database, insurance database. All the people have social security completely free in this country. It looks a little more like France than the US. And they have, but better than France, they have a very good analysis of the diagnosis. And they found that. They tried to adjust it, but we have to be very cautious with that. Because, of course, the patients treated with anti-TNF are, even if you adjust, maybe are not the same as a patient treated with classical DMARD. Because, but anyway, in this paper, the risk of cancer was lower in this patient treated with anti-TNF. Last, we have now data from patients with previous cancer, because all the patients with cancer for the 5 previous years classically are excluded from anti-TNF. It explains the difference of baseline characteristics between the patients. But we have this data from UK also, and you can see here, if you compare 120 women with a previous breast cancer, but a long time ago, because it is, you see, 9 years, to the same group of patients, sex of course, but age-matched with classical DMARDs, there is absolutely no differential risk of recurrence of breast cancer in these women. It means that with cancer for more than 5 years, you can be really confident now to use anti-TNF if the cancer is cured. What about lymphoma, which is a specific cancer which is very interesting in RA? You all know that there is a 2 to 3 fold increased risk of lymphoma in patients with RA, which is linked to the activity of the disease. It has been well demonstrated 10 years ago by the Swedish that the 10% of the patients with the highest activity have the highest risk of lymphoma. And we are going to treat these patients by anti-TNF, of course, the highest patients. So what will be the result of that? If you look at meta-analysis, very reassuring. The Cochrane meta-analysis shown that the risk of lymphoma was 0.5 is a patient treated with anti-TNF compared with a patient treated with placebo. But again, selection of the patients, short-term follow-up. So we did the same meta-analysis of lymphoma in the registries, and we found no difference between anti-TNF and classical DMARDs, as you can see on this slide. We found, as expected, higher risk of lymphoma if we compare with the general population. The standardized incidence ratio was 2.5. It's not a lot because, again, we deal with the more severe RA patients. And we, in our study in France, the ratio study, we could collect prospectively for 3 years 38 cases of lymphoma. So it's a lot because we collected the cases all over the country. We had a network in hematology, oncology to have all the patients because the patients are hospitalized. And we could describe this population. And we found, we calculated the standardized incidence ratio compared with the general population. Overall, we had 2.5, 2.4. It was exactly what expected and even lower. But we were very surprised. Because we had with a monoclonal, we had 3.7, and it is something which can expect with high activity patients. But with etanercept, there was some, like if the risk of lymphoma could come back to the risk of the general population. And if we deal with a patient having received only one of the drug, because, of course, if they have received both, it's difficult, but we have 31 with only one drug, we had exactly the same difference. So it is puzzling. Now we have new data from the BSR-BR. The BSR-BR now, they have analyzed, you see, 47 lymphoma in this paper, 18 in the etanercept, and 29 in the classical DMARD cohort. And they compare. And they found that the risk of lymphoma was lower in etanercept than in methotrexate in this registry. I am very cautious with that because we don't have the data with adalimumab and infliximab, because this data have been given to the Pfizer guys because it is a contract. So they give the data from the control group and from the drug to each company. And the Pfizer guys, they worked with academics, with statisticians, and they published this data. This data is certainly right, but we would have loved to have the data with adalimumab and infliximab also. And there were also a decrease in mortality compared with methotrexate in these patients, UK patients treated with etanercept. So when you treat a patient for lymphoma, and that's very important in this type of meeting, you do two things concerning lymphoma. When you treat a patient for RA, you do two things. First, you decrease the risk of lymphoma because you decrease activity of the disease, and that's very, very important. But second, you may impair some immunosurveillance mechanisms. And if these immunosurveillance mechanisms involve some cells expressing membrane TNF, and NK cells express membrane TNF, for example, you can impair immunosurveillance and have a deleterious effect. And the balance may be different between the type of drugs. And now in the lab, we are studying that. We have a mouse model of autoimmune disease, BAF transgenic mice. We can get lymphoma. And we treat these mice with different type of anti-TNF, and we see what happens. And again, we also look at the NK cells from patients treated with different type of anti-TNF, and we look what happens. So just 2 slides on cardiovascular events. Because of time, it's very important from the Corona registry in the US. Anti-TNF can decrease in this registry. You see the rate of major cardiovascular events, and that's very important. It is a composite score. Every item of the composite score is involved by this decrease. And again, interestingly, in the Corona registry, the deleterious effect of steroids. Look at the effect of steroids, even at low dose. You increase the risk of cardiovascular event by 78% in the Corona registry. There is meta-analysis confirming that, this one and a recent one recently published by the Canadian group in the Annals of Internal Medicine showing the reduction in the risk of cardiovascular event. So just a few, 2 or 3 slides concerning other biologics because we don't have yet long-term extension of this registry and a lot of data. Meta-analysis, you see abatacept is in the left, concerning the risk of serious infection, meta-analysis of RCT, and you have rituximab, you have tocilizumab here. We have the data from the German registry. It is maybe the only data we have, and interestingly, it fits very well with the meta-analysis of RCT. If you compare with TNF, the risk of serious infection is a little decrease with abatacept, the same with rituximab, and a little increase with tocilizumab in the German registry in this data recently published. In France, here our registry, we have the 3 registries dedicated by each drug, rituximab, abatacept, and tocilizumab. And you can see the rate of serious infection. We are going to do some comparisons. They have not been yet. It's not published, this slide. You see between 3 and 5 per 100 patients here. It is the number you have to keep in mind. Maybe a small decrease with abatacept, but roughly the same between the different registries. Concerning the, we had this, I skip, excuse me. Concerning the cancer with the 3 drugs, we need more time. Here our data in France, and roughly it is around 1 per 100 patient years. And you see, we find that. You see the rate of cancer, and today we cannot draw any conclusion of that concerning the risk of cancer with the other non-anti-TNF drug. And last, for finishing, just if I have just 1 minute just showing effect of anti-TNF on mortality, because it's very important. Are we going to allow our patients to live more? In the BSR-BR, at that time, no difference in mortality between anti-TNF and the drug. But we have now published the data from the German registry. And look at the power of this registry. We have 30,000 patient years, 500 patients died. So you can really calculate it. The risk of mortality. You see, the SMR is still high in RA, 1.5. And look at the first data. Activity of the disease, it's the mean activity of the disease by DAS28, increases the risk of mortality. Second data, steroids increases the risk of mortality. It is clearly indicated here. Of course, it is adjusted on everything on what you can adjust it. But last but not least, the fact of being treated with anti-TNF or being treated with rituximab decreases the risk in the last 6 months, decreases the risk of mortality. And the first time I've seen the type of data, of course, they have to be confirmed, but they are very interesting. You see here, ever treated with TNF or rituximab also decreases the risk of mortality. So to conclude, there is a higher risk of serious infection in the first year of anti-TNF, the same with all anti-TNF. Interpret with caution long-term safety result because of the healthy drug survival effect. There is a higher risk of TB with monoclonal and soluble receptor, but TB is much, much lower incidence than classical serious infection, and it is linked to the fact that the monoclonal work in Crohn, work in uveitis better than soluble receptor, probably work a little better in psoriasis, and there is the counterpart of that is the higher risk of TB because the effect of membrane TNF. Recent data from both Registries and RCT are reassuring concerning the absence of risk of cancer with anti-TNF except non-melanoma skin cancer. No overall risk of lymphoma with anti-TNF, a possible difference of lymphoma risk between the drugs, but I am very, very cautious about that. It has to be confirmed. A possible prevention of cardiovascular event. And last, a possible beneficial effect of biologics on overall survival of our patients with rheumatoid arthritis. Thank you very much for your attention.